From the Sumaira Foundation, this is Demystifying NMO and MOG, where we bring together the world's foremost experts, the doctors dedicated to studying it, and the patients who live with it every day. With support from Genentech. Welcome back for another episode of the Sumaira Foundation's Demystifying NMO and MOG. This episode wraps up the show's third season and my first. I'm glad you stayed with us as we grew and I settled in. We've been busy planning season 4 and have our own ideas, but we would love to hear from you. What topics do you want to learn more about? What challenges are you facing as a patient or caregiver that we can help shine the light on? For clinicians who are listening, what information can we help connect you with? Who do you want to hear from? We definitely want to hear from you. So you can email us at podcast@sumairafoundation.org, or you can find us on Instagram, Twitter, or Facebook. The links are all going to be listed below in our show notes. Finally, remember that no matter how you listen to us, subscribe so you get the newest episodes right away. Now for today's episode. You always know fall is around the corner because pumpkin spice lattes have arrived at every coffee shop. But here in the United States, it also signals open enrollment time for organizations when they're updating their employees' health insurance plans or when people are able to make changes in health insurance exchanges. Now, we can probably all agree that dealing with health insurance can be a hassle for anybody, but switching plans can be especially stressful for people with a chronic illness. So today, I'm joined by Amy Niles of the PAN Foundation. PAN is the Patient Access Network, and it provides financial assistance to Americans to help with health expenses. Now, they're recognized as one of Forbes' top 100 charities, and they've helped people pay for billions of dollars in healthcare. Yes, billions, with a B. Amy Niles is their Chief Advocacy and Engagement Officer, and as you're going to see, her knowledge and passion make her an incredible advocate and the perfect guest for today's episode. Hi, Amy. Thank you so much for coming on to the show today. Really appreciate it. Let's start at the beginning. Can you tell us all about PAN?
Sure. And thank you so much for inviting PAN to participate. Today, we have so enjoyed our partnership with the Sumaira Foundation. It's been truly valuable for the patients that we help. The Patient Access Network Foundation, we're commonly referred to as the PAN Foundation, has been around for 20 years. We are a national patient advocacy organization, a charitable foundation that helps underinsured individuals who are living with life-threatening chronic and rare diseases get the medications and treatments they need. And we do this by assisting with their out-of-pocket costs for prescription medications. We also do this by advocating for improved access to care and affordable care. Today, we operate more than 75 different diseases and funds where we provide assistance to individuals who are living with these chronic conditions. These diseases cover many cancers, lung cancer, breast cancer, prostate cancer, many chronic diseases, and rare diseases as well. In a few areas, we're also providing assistance toward their premiums, insurance premiums. That's in just a few areas. And also importantly, for people who are enrolled in our funds, we have a transportation fund, which is important because at the end of the day, we want people to be able to get to their healthcare providers, get to their pharmacies, to pick up their prescriptions, even be able to get to their supermarkets so that they can buy food to stay healthy. So that's an important program that we operate. Over 20 years that we've been around, we've helped more than 1 million people get access to the treatment they need. And we've provided more than $4 billion in financial assistance, which is a lot of financial support. And yet we know that we're only really tapping the surface of the people who need our help.
That's amazing. The reach and the impact is incredible. So you're the Chief Advocacy and Engagement Officer. What does a day in the office look like for you?
That's an interesting question. So I'll take today as a good example. I'm doing a podcast with one of our greatest alliance partners, the Sumaira Foundation, because at the end of the day, we want people to know about the availability of patient assistance. In a couple of hours, I'm going to be having a Hill visit with a member of Congress to talk about some important legislation that we've been advocating for that we hope he will support as well. And then following that, I'm having some conversations with other patient advocacy organizations about the new CMS guidance that was just issued a couple of days ago regarding one of the Medicare reforms that was passed as part of the Inflation Reduction Act, because we all are submitting our comments back to CMS within 30 days. So I have a very varied day, which makes my work really enjoyable. One of the things that I always look forward to, and I don't have this today, but I had it yesterday, is actually speaking to our PAN grantees. So for example, we have a patient and family advisory council that's made up of individuals who have benefited from PAN assistance, and we have leveraged their support. They participate on panel discussions with us. We have great relationships with them. And so I always enjoy the opportunity to speak one-on-one with our patients.
That's incredible. You mentioned your alliance with the Sumaira Foundation. How can the PAN Foundation help people with NMO?
So I mentioned that we have more than 75 diseases and funds where we provide assistance. One of those funds is for individuals who are living with neuromyelitis optica spectrum disorder. And so for individuals living with this condition, they are able to seek support, financial assistance from the PAN Foundation if they meet certain eligibility criteria. And our eligibility criteria are pretty common across all of our disease areas, and they differ in a few ways. But for our NMO fund, an individual must be being treated for that disorder. They need to be residing and receiving treatment in the United States or one of its territories. And by the way, we don't require citizenship documentation. They have to have health insurance that covers the medication. So in essence, PAN becomes the payer of last resort. But for this fund, it can be federal insurance like Medicare or commercial insurance. They must have been prescribed a medication that is on our list of medications that are covered. And our website lists all of our disease funds. It lists all of the medications that are covered. And by the way, that's all FDA approved brand and generic medications. And they have to have income that is at or below 500% of the federal poverty level. Now, most people don't know what that translates to. So I'd like to give a couple of examples. So for example, if you're in a family of two, that would mean you have an annual household income of at or below $98,600. If you're a family of four, that goes up to $150,000. So it's fairly generous. So if you say yes to all of these eligibility criteria, and the fund has available funding in it, today it does, you're eligible to receive a grant of $4,800 that covers 12 months of your out-of-pocket costs for your medication, deductibles, copays, co-insurance. So we design our grant amounts to meet the majority, if not all, of one's out-of-pocket costs for the year. However, there are circumstances we know where patients may run out of money sooner, and in that situation, they are eligible to apply for a second grant during the 12-month period. And then about a month prior to when that 12-month period ends, the patient will get a notice and they can apply for a second grant for the next 12-month period. You're probably going to ask, well, how does a patient apply? It's really easy. There's so many barriers to accessing care. We try to eliminate all those barriers and make this process as easy as possible. And it literally just takes a few minutes. So people call us. We have a call center. Many people in our call center who are there every single day, Monday through Friday, 9 to 5:30 p.m. Eastern Standard Time, to help patients enroll in our funds. And that number is 1-866-316-7263. People can also apply online very easily, and they can start that process at panfoundation.org. Another URL is panapply, all one word, .org. The patient will be walked through the questions. They, if they answer yes to all the questions and we have funding, they will know instantaneously that they have been approved for a grant, and they will have an ID number that they'll be able to take to the pharmacy counter and start benefiting from the assistance that we provide right away.
It always seems like getting through an application process and then the wait afterwards is always terrible. There's so much anxiety involved with it. So it sounds like you've really streamlined it and really made it easy to get through.
Yeah, and there's, if I had to summarize the 5 pieces of information that patients will need to provide to us, it's their diagnosis, it's the name of the medication that they need help with, it's their healthcare provider's name and his or her contact information. We'll need their health insurance, because again, we're the payer of last resort, and their ID number. We'll need the patient's name, email, and social security number. And finally, just their adjusted gross household income. But we don't ask for any documentation. So again, it is quite easy. And within minutes, they'll know if they are approved or not.
That's fantastic. So as of right now, PAN doesn't offer a program for people with MOG. Any advice for someone if they cannot find their illness in the Fund Finder? And can you even talk a little bit more about the Fund Finder itself?
Yeah, Fund Finder is a great tool. It's a great tool for patients, for healthcare providers, even staff in call centers and in patient advocacy organizations. There are 9 organizations, we are one of them, that provide copay assistance. It's really hard for anyone to know who these 9 organizations are and what programs they offer. And in fact, collectively, these 9 organizations, including PAN, provides assistance across more than 200 patient assistance programs. So we wanted to do something about 4 years ago that would help patients and providers. And we created a web app called Fund Finder. And people can register for it really easily at fundfinder.org. And what we did through technology is just bring all of this together in one place. So very easily, you can see what organizations are offering assistance in what programs. But here's the nice, useful way that Fund Finder is used. This could be for NMO. Actually, we're the only patient assistance organization that provides assistance in this area. But let's just take another illness. It could be asthma. It could be any other chronic condition. You'll get to see what foundations offer assistance. And let's just say, for argument's sake, there are 3 patient assistance organizations that offer assistance, but maybe today we're all closed, which means we don't have any funding today. If you register for fundfinder.org, and if you say, I'm interested in this particular disease, you'll get an email notification when one of the foundations opens up. And that's really important, because it's going to prompt you to go to that foundation as quickly as possible to apply for assistance. So it's a great tool. One of the things I didn't mention about our funds, which is important for patients to know, is some of our terminology. So when a patient goes on to panfoundation.org, goes to NMO, or goes to any one of our other disease funds, they're going to see terminology like it's open, closed, and our wait list.
Okay.
If the fund is open, like NMO is today, we have funding available, one can apply, and one can get assistance. If the fund is marked closed, it means that unfortunately today we've run out of funding. Hopefully soon we can reopen the fund, but that is a prompt for the patient to put their name onto our wait list, and there'll be an easy way to do that. That is really, really important, because the wait list is first come, first serve. So when we're able to reopen that fund, because we've got funding in, we're going to reopen it first to people on our wait list. So it's really important for patients to add their names to the wait list if they find that that fund is closed.
Excellent. Along with aligning resources to help people pay for medical care, a large part of what PAN does is advocacy. And you touched on that a little bit earlier. I was hoping we could talk about some of the important issues that patients are facing when it comes to accessing medical care. So, to start with, the Inflation Reduction Act had some important provisions that will affect people on Medicare. Can you tell us a little bit about that?
Happy to. And PAN Foundation advocated for these reforms for many, many, many years. So we were happy to see that 6 Medicare reforms were included in the Inflation Reduction Act, which passed just about a year ago on August 16th, 2022. 2 of those reforms are already in effect. They went into effect at the beginning of this year. And that is for, and this is all for people on Medicare, that there would be no copays associated with vaccines. That was a really important reform that got passed and implemented January 1st. The other important reform that's already in place is the cap on insulin, where people will not pay more than $35 a month for their insulin. Great reform. As we look toward January 1st of 2024, so just a few months away, there's 2 more reforms that go into effect. One is an expansion of the federal, what's called low-income subsidy program or extra help program. This is for people who have lower income, up to 150% of the federal poverty level. And it's a little complicated program, and I won't go into all the details, but currently there are 2 programs. One is partial and one is full. And what the Inflation Reduction Act did was eliminate the partial program. So now more people will have access to the full program, which means more people will have the majority, if not all, of their out-of-pocket costs covered. Again, up to 150% of the federal poverty level. The second one is really important because it is the first step towards significantly lowering out-of-pocket costs for prescription medications for people on Medicare. And this is above that 150% level, because we hope that those individuals will apply for the extra help program. Without getting too, I always like to use the term wonky, but trying to simplify this. Today, the Medicare benefit is pretty complicated. Today, if you have spent up to about $3,100 in out-of-pocket costs, and for many who are living with a chronic condition and they've been prescribed a specialty medication, that's not very hard to do. So if they've spent up to about $3,100, they are then propelled into what's called the catastrophic phase of their benefit. And now they're spending 5%. They need to spend 5% of that drug list price until the end of the year, and there is no limit. And up to this point, Medicare beneficiaries have been the only group in the United States that does not have a limit on what they spend out of pocket for their prescription medications. So what goes into effect this coming January 1st, that 5% goes away, and now there is a limit. And in essence, people on Medicare will not pay more than around $3,250 for their medications. So big improvement. What happens in 2025 is significant. So it sounds like it's a really far away, but it's 16 months away. In 2025, there will be a cap of $2,000. So no one on Medicare will spend more than $2,000 a year for their prescription medications. That's a big improvement. Again, especially for people who have been faced with such high out-of-pocket costs for specialty medications. On top of that, the health plans must offer people, Medicare beneficiaries, the opportunity to spread out their costs throughout the benefit year. So right now, what happens is that often Medicare beneficiaries are faced with really high costs in January when their deductibles reset. Now they'll have the opportunity to spread that out. So imagine if you were faced with high costs and you opted in to spread out these costs at the beginning of the plan year. In theory, it's not going to be this simple, but in theory, you might have $167 max for every month, that $2,000 divided by 12. Again, it's not going to happen quite that easily because we like to do things in a complicated way when we implement reforms. But what's important is that now patients have a cap, and patients can have greater predictability and affordability with this opportunity to more evenly spread these costs.
Those are all significant changes.
They are steps in the right direction. That said, we know that there are many, many individuals who will still find the $2,000 to be a challenge. We know, people of color, people of low income, people with chronic conditions will still have challenges, but it is a step in the right direction.
Yes. So last fall, I was attending the Pennsylvania Rare Disease Advisory Council Summit, and copay accumulators were mentioned, and I wasn't very familiar with it. So as I started reading about them, I came across alternative funding programs, and they seem very similar, very complicated, and very determined to shift healthcare costs away from insurance companies and onto the patients. Can you tell us a little bit more about them? Like what they do and how do they impact patients?
Thank you for asking me this question, and I agree with you. It's a way for plans to try to lower their costs, shift the cost to the patient, and at the end of the day, at PAN, we believe these are all harmful programs to patients and should be banned. They are complicated. A plan that has a copay accumulator program in place is basically saying that a patient can seek financial assistance from a third party or anywhere else, for example, a manufacturer coupon, but they're not going to count the value of that coupon toward a patient's deductible or annual out-of-pocket limit. So let's take an example of a patient who may have a deductible of $2,500 and they have sought assistance from a manufacturer, and the value of that coupon is $500. If that patient's plan does not have a copay accumulator policy in place, that $500 coupon will count, and the patient will have to pay $2,000, not their full $2,500. If there's a copay accumulator policy in place, they've used that $500, it doesn't matter. It's not counting. They're liable for the full $2,500. So it puts more financial burden onto the patient. It takes them longer to reach their deductible. And we think these policies are somewhat discriminatory because it's affecting people who have serious chronic illnesses. They're going to the manufacturers for assistance for specialty medication. Likely there may not be a generic equivalent, and it may be the only place they can turn for assistance. One of the problems we know exists is that there's very limited transparency in the health plan documents around copay accumulators. Patients may not even know that they exist. And language is used that often is quite confusing. So the plans might actually say they have a copay accumulator program. You can find that in their language, but they could also use terms like a benefit plan protection program or out-of-pocket protection program or a primary coupon adjustment. So in a patient's mind, when they read this, it may actually sound really positive, but it's not positive. It's hurting the patients. So when it comes to copay accumulators, it's important to know what's in that patient's plan. Importantly, there is federal legislation that we advocate for that will ban these programs, and it's called the Help Copays Act. And we're working hard alongside many, many other organizations to get this bill across the finish line. It has bipartisan support, tremendous support from the patient advocacy community, and we're hoping to see some movement, maybe even by the end of this year. Right now, we know that there are 19 states and District of Columbia and Puerto Rico that have passed their own legislation banning these practices, but federal legislation is needed. Now, alternative funding programs is another matter. It is very, very complicated. I'll try to make this as simple as possible. These are egregious practices on the part of plans and PBMs. What employer-sponsored health plans are doing with the encouragement of PBMs is this is a way to lower our costs. We're going to say that specialty medications, maybe in a particular therapeutic area, or maybe across the board, are deemed a non-essential health benefit, and we're not going to cover them. Now, that's problematic in and of itself because the plans know that prescription medications is an essential health benefit. Specialty medications should not be any different. But they're saying we're not going to cover it. It's a non-essential health benefit, but employee, patient, if you need financial assistance, we're going to refer you to a company called an alternative funding vendor who can help you find assistance. Now, Brian, by the way, these vendors are not insurance companies. They're separate companies that have their own financial relationship with the health plan. And what they're doing often is asking the patient for their personal information. Sometimes they're asking them to sign a power of attorney, which is problematic, so that they can help get assistance. Sometimes they're importing medications from outside the United States to help the patients. Another way it's problematic. They're trying to go to the manufacturer, charities like PAN, to find assistance. Sometimes they're successful, sometimes they're not. But from our perspective, we deal directly with their patients. We deal directly with their healthcare providers. These vendors are often not authorized to act on behalf of patients. So it is problematic on many, many different levels. At the end of the day, it's another way where patients are getting caught in the middle and are not getting access to the medications they need. So there's no legislation yet to ban these programs. We're doing all we can to educate people, other patient groups, provider groups, patients, people on the Hill about these practices. It has raised a red flag with several federal agencies that are looking into these practices: Department of Labor, Federal Trade Commission, the FDA regarding the importation matter. So we know that it's gained the attention of agencies. And so again, I think patients need to be aware that if, from their employers, if they're told that their medication is deemed non-essential, there may be an alternative funding program at play here.
It's absolutely predatory.
Yeah, there are many words that have been described that have been used to describe these practices. Just like the Copay Accumulators, maximizers, alternative funding programs need to be banned.
So you mentioned PBMs, and that's pharmacy benefit managers. Is that right?
That's correct. Yeah.
Oh, okay.
Yeah.
Couple follow-up questions for you. Are these copay accumulators and AFPs, are they found primarily in certain types of insurance? Is it private insurance, like through an employer, or are they in the ACA marketplace programs?
Yeah, the Copay Accumulators are on the ACA market plan. So this is primarily affecting people with the commercial insurance. The AFPs are more of the employer-sponsored health plans. And, what the PBMs are doing is, saying to these plans, hey, you have employees that have chronic illnesses, might be a small percentage of the people that you help, but they're going to require specialty medications. And that's where your costs are going to rise because there's such high costs associated with the specialty medications. So this is a way that you can lower your costs. The alternative funding vendors can help, find the individuals, the assistance they need from the manufacturers and from charitable foundations.
It's really marketed as, hey, this is a great benefit for you and your employees, but the mechanics behind it are pretty
correct. It's marketed as a way to lower your costs, There's no transparency for the employee. So when the employee finds out that specialty medication is not covered, they're shunted over to a vendor. And as I described, there's all kinds of issues that result. At the end of the day, it could be that the employee gets the medication they need, either from the pharma. Maybe they go back to the plan and through an exception process, they get the approval. But what happens, even when they get the approval, weeks have gone by and they've had a big delay in starting treatment, which is problematic for patients living with serious illnesses. So we're doing all we can to raise the attention around these programs. And as I said, ultimately, it might be that legislation is needed to ban them.
With that delay of treatment, not only the lack of the medication, but most people who are chronically ill, stress becomes a major trigger for flare-ups and things like that. So you're just adding
Absolutely.
fuel to that fire. You mentioned transparency a few times, and it definitely seems to be lacking. When I was doing research on it, it was very tricky to find information about copay accumulators. So if you were to sit down and read through the jargon and the legalese and try and find out if your plan has one, can you call the plan? Do they have to tell you, or is it all just very masked and you find out when it's usually too late?
Sometimes that happens, and that's the problem. You find out when you get to the pharmacy counter and you realize that drug coupon has not been counted toward your deductible. And in order to walk away from the pharmacy counter with your prescription filled, you have to pay 500,000 or even more dollars. So that is problematic. Yes, I think patients can call their plan and ask if they have a copay accumulator program in the plan. They can ask directly using those words. They can say things like, if I get assistance from a manufacturer, will that assistance count toward my deductible and out-of-pocket maximum? That's another way of asking the same question. And it should be easy for the plan to say yes or no.
It's very important to make sure that we know the questions that we need to ask to make
Exactly.
sure that there's no wiggle room, that they have to give us
Yes.
that information. So you had mentioned about legislation making these type of programs illegal. And towards the end of the Trump administration, rules were approved giving healthcare insurance companies and PBMs the ability to implement accumulators and such.
Mhm.
And President Biden has issued an executive order directing the Department of Health and Human Services to review these issues. And I don't think there's been a lot of movement regarding them. Even recently, the Center for Medicare and Medicaid Services issued some new rules on benefits, and they were silent on copay accumulators.
Yep.
Is there a reason? Is it a reluctance or just process? What's holding back action on these issues?
That is a great question, Brian. And we have worked with a coalition called the All Copays Count Coalition exactly on this. Every year over the last few years, when there has been an opportunity to address copay accumulators, we have strongly encouraged CMS to do so. And there has been a reluctance. I'm not sure it's an oversight or a process thing. Plans want to lower their costs. There are many out there who simply do not like the ability for pharmaceutical manufacturers to provide drug coupons. There are some who believe that drug coupons are just a vehicle to enable companies to continue to raise their drug prices, just get more and more folks on their branded medications. For us, we think it's a good thing if people can start treatment. And,
Right.
and oftentimes that coupon enables someone to do so. And oftentimes there is no option. There's no generic equivalent. So hard to know exactly why it hasn't happened. And for that reason, that's why we are advocating for this federal legislation. which is the Help Copays Act. It is bipartisan. It's been introduced on the House side, HR 830. It's been introduced on the Senate side, S 1375. We're gaining more and more traction every single day. People in Congress are signing onto it. So we're hopeful. It may be if to get this across the finish line that it needs to be included in a more robust package that's addressing PBM reform. And we know that Congress right now is very interested in PBM reform. So we're just keeping our fingers crossed that we can get the federal legislation move forward. As I said earlier, 19 states, DC and Puerto Rico, have already passed legislation. So there's interest, there's knowledge that these practices hurt patients. So I encourage, all patients, providers, patient groups to speak to their elected officials to encourage the Help Copays Act to be passed. We actually, on our website, which is panfoundation.org, under the Advocacy, we have an online campaign. People can go there today and with a click of a button, sign a letter or get a letter sent to their members of Congress encouraging them to pass this bill.
I'll make sure I include a link to that in our show notes. It's really important that people get involved in this and make sure that their voices are heard, because if not directly for oneself, I'm sure everybody knows someone who is either in this situation or are going to be in the future. And so it's really important that it's addressed and that there is some action moving forward.
Yeah, and we also encourage patients to share their stories. Sometimes it's hard to get stories, especially around copay accumulators or even alternative funding programs. But those stories kind of bring the issue to life, especially for people on the Hill. So it's important for patients to do that as well.
Well, thank you so much for talking with us today. Thank you for the work that you do and all the effort that PAN puts into helping people get care. There was a lot of great information, and I think people are going to find it very helpful. So I appreciate you for joining us.
Thank you so much, Brian. At the end of the day, we really do want patients to know that there's assistance out there. And again, thank you to the Sumaira Foundation. We work very closely with the foundation. We focus on the financial assistance, but we know that the Sumaira Foundation does so much to help provide the needed education and support to patients. So appreciate that, all that you do, and look forward to continuing to work together.
Fantastic. Have a great day.
Thank you. You too.